Assalamu alaikum everyone. This is the second portion of the burn in which we will discuss about the diagnosis and management of the patient with burn. Burn study is based on clinical history and physical examination. Pulse oximetry is done to monitor for hypoxemia and in case of circumferential limb wounds, assist perfusion via pulse oximetry, capillary refill and peripheral pulses to monitor for ischemia and compartment syndrome. Different types of blood tests like blood gas analysis to monitor for hypoxemia and acidosis like metabolic and respiratory. Serum electrolytes to monitor for hyperkalemia and hyponatremia in the acute phase and hypernatremia in the post-acute phase. And burn and create to monitor for acute renal injury. Hemoglobin hematocrit to monitor for hemolysis. Protein and albumin to monitor for hypoalbuminemia in acute phase. Wound swab and culture are in case of suspected wound infection or sepsis. Now treatment of the burn. So first we will discuss the treatment of the minor burn. So in minor burn we have management of the burn area like remove clothing, dirt, debris, cool with room temperature or with cool running water. Wound irrigation. So irrigation is done with the mild soap and water. Topical moisturizer can be applied for the systemic relief of first degree burn. Consider deroofing of the blister. Consider antiseptic ointment or topical antibiotics for the second degree burn. Wound dressing is indicated in second degree burns. Types of dressing like paraffin, impregnated gauze, hydrocolloid dressing, biosynthetic dressing, wet to dry dressing. And these are indicated for the patient having infected wounds or wounds with devitalized tissue. Pain management can be done with acetaminophen and prophylaxis of the tetanus is given with tetanus vaccine. Management of the moderate and major burn. So initial management, immediate management of moderate and major should prioritize the ABCDE approach. Airway should be checked. Intubation is indicated if inhalational injury is suspected or a burn involved greater than 30% of the surface area. Do not delay intubation if needed as fluid resuscitation can increase laryngeal swelling. Then we have to check for breathing and administer 100% oxygen if carbon monoxide poisoning is suspected. Sclerotomy is indicated in circumferential burns of the trunk and neck. Then we have to check for circulation. So fluid resuscitation with crystalloids is indicated to ensure sufficient perfusion in patient with major burn. Ringer lactate is preferred over hypertonic saline because hypertonic saline may cause hyperchloremic metabolic acidosis. Volume for 24 hours for initial fluid therapy with Ringer lactate is calculated using Parkland formula, which is 4 ml multiplied by percentage of the total body surface area affected by second and third degree burns multiplied by weight in kg. Because of the risk of complications, Parkland formula is adjusted as follow. Like for individual greater than 14 years of age, half the volume of the calculated using Parkland formula. So half of the volume is given to the patient having age greater than or equal to 14 year. Individual less than 14 year of age having weight greater than 30 kg. So the formula is given as 3 ml multiplied by total body surface area affected by second and third degree burn and multiplied by weight in kg. So instead of 4 ml, 3 ml is used for the individual having less than 14 year of age. And children having less than 30 kg of the weight, 24-hour initial fluid should be followed by 24-hour of maintenance fluid therapy with a glucose containing solution is required. Maintenance fluid is calculated by the rule known as rule of 4, 2 and 1. So 4 to 1 rule means that for the first 10 kg we multiply it with 4. For the next 10 kg we multiply it with 2 and for the remaining weight we multiply the weight with 1 ml. Like for example, if a patient having weight of 30 kg, so for the first 10 kg we will multiply 10 kg with the 4, it will give us 40 ml. For the next 10 kg we multiply 10 with 2, it will give 20. So 40 plus 20 60, and for the next 10 kg we will multiply it with 1. So 40 plus 20 equal to 60 and plus 10 equal to 70. So 70 ml per kg per hour will be the maintenance fluid for the patient. So remember rule of 4, 2 and 1, which is per hour. While for the calculation of the fluid per day, we can use the formula of 100, 50 ratio 20. So it means that For the first 10 kg, we will multiply it with 100. For the next 10 kg, we will multiply it with 50. And for the remaining kgs, we will multiply the remaining kg with 20. So remember that half of the fluid volume that is recommended should be administered within first 8 hours. Like 50% should be administered within first 8 hours, and the remaining half will be administered over the course of next 16 hours. So it is divided into two portions. Combining crystallite with colloid like albumin, plasma, or high dose vitamin C can reduce fluid requirements. After initial stabilization, patients who require aggressive resuscitation should undergo urethral catheterization to monitor urine output and adjust fluid accordingly. So fluid is adjusted in accordance with urine output. Target urine output is 0.5 ml per kg per hour for the adults and 1 ml per kg per hour for the children less than 30 kg. Management of the burn area. So remove clothing, dirt, debris, cool the burn area with room temperature or cool running water or saline soaked gauzes, and cover the wound with a sterile dressing. Core body temperature should be monitored for hypothermia. If body temperature is less than 35, warm IV fluid can be given. Cool with caution or not at all in patient with burn surface area greater than 10% because of high risk of hypothermia. Because the risk of serious complication, the fluid of the resuscitation volume calculated using Parkland formula. In individual greater than 14 years, the volume is administered over 24 hours of the period, with one half given the first 8 hours and the remaining half over the next 16 hours. Because fluid resuscitation can worsen laryngeal edema, so intubation should be performed as early as possible. Do not use ice or ice water. Then we have subsequent management. So what are the indication for treatment in a special burn unit? So special burn unit treatment indication are second degree burn involving greater than 10% of the surface area or third degree involving greater than 5% of the surface area. Inhalational injuries, burns involving the hand, feet, genitalia or major joints, high voltage electrical burns and chemical burns. Then we have wound care. So early debridement of necrotic tissue, wound dressing depend on specific burn characteristic, often include free skin graft, flap reconstruction, and topical antibiotics can be given. Nutritional supports, enteral feeding via NG or nasal is preferred over parenteral due to risk of liver injuries and electrolyte imbalance. Early initiation of nutritional supports help to control the hypermetabolic response. Pain with NSAID and opioid, anxiety with benzos, and prophylaxis treatment is given like PPIs or H2 antagonists for the curling ulcer due to stress. Vaccination like tetanus prophylaxis and antibiotics are given. Specific consideration like scars. For the scar, those which are circumferential scars, perform a Doppler and check capillary refill, peripheral pulses, sensation and pulse oximetry in the limb. Hourly for 24 to 28 hours to assess for vascular respiratory compromise or compartment syndrome. No vascular respiratory compromise or compartment syndrome, so raise the leg or upper body and perform a range of motion exercises tolerated. Vascular respiratory compromise is present, so do the sclerotomy and fasciotomy. Fasciotomy is indicated if compartment syndrome develop. Chest or neck scar, so sclerotomy in impending or active respiratory compromise is done. Then we have chemical burns. So chemical burns, immediate copious irrigation of all areas of exposure with water. Remember, burns from dry lime, phenols and metals should not be irrigated. And these are different types of complication like shock, sepsis and respiratory failure, which is most common cause of death from the burns, and these are the different organisms involved. Then we have circumferential burn may lead to compartment syndrome, acute limb ischemia, abdominal compartment syndrome, increased abdominal pressure leading to JVP, raise distension of the JVP, hypotension, tachycardia. Then we have stress ulcers, keloid formation, marginal ulcer, and complication of chemical burns like cataract or vision loss if it involve the eyes, esophageal structure if burns involve the esophagus, and systemic poisoning. Complication of electrical burns are arrhythmias. In view of inhalational injury is damage to respiratory tract that occur following the inhalation of hot smoke and are noxious gases. And inhalation of hot smoke or particle less than 1 micrometer diameter in size and are irritant or noxious gases. For example, ammonia, chlorine, these are the underlying etiologies. Diagnosis. So, in diagnosis, inhalational injuries should be suspected when any of the following are present. Like history of being in confined space, facial burn or burns, eyebrows and or nose hairs, evidence of soot on the face or in the airways, stridor, dysphonia, extensive burn. In suspected inhalational injury, these are the following investigations to be done. And treatment is intubation and high flow oxygen therapy. And these are the different complications: pneumonia, ARDS, arsenic poisoning, carbon monoxide cyanide. Prognosis or resolution often occur spontaneously within 2 to 3 days. Then we have another complication known as post-burn hypermetabolism. So this occurs in patients with moderate to severe burn injury and characterized initially by hypometabolic phase followed by hypermetabolic state. An increase in catecholamine, cortisol, and inflammatory cytokines are possibly involved in the underlying pathogenesis. There will be elevated resting energy expenditure, increased insulin resistance, increased gluconeogenesis, increased lipolysis, and protein catabolism. Clinical features: so first you hypometabolic phase known as F phase onset within 48 hours of the injury. There will be decreased cardiac output, oxygen consumption, and metabolic rate. So these all will be decreased in hypometabolic phase. Then you hypermetabolic known as flow phase. It starts about 5 to 7 days after the injury and can persist up to 3 years. There will be hyperdynamic circulation like increased BP, increased heart rate, muscle wasting, protein loss, significant weight loss, hyperglycemia, increased body temperature, and multi-organ dysfunction. Management: so early excision and grafting of the burn, analgesia is given, nutritional support is given, anabolic steroid to prevent the protein catabolism, glycemic control with insulin and beta blocker due to catecholamine surge. There are symptoms occur, so beta blocker is used to decrease the resting metabolism due to catecholamines and other symptoms. So that's all about burns.